Thank you and good afternoon again. Thank you for joining us for today's session, Sitting with Safety, applying the International Pressure Injury Prevention and Treatment Guidelines, specifically looking at the new seating and postural care consideration chapters. Our goal today is focused and practical to bridge the relevant guidelines with the real world decisions that we make in clinical practice, hopefully helping you to interpret the relevance of these good practice statements for clinical decision making and then translating this into clinical application. By the end of the session, hopefully you'll be able to translate the latest guidance into actionable strategies for seated postural care, to recognise the unique risks and the needs of seated individuals in relation to pressure injury prevention, and apply the evidence-based principles to be able to optimise posture, to enable repositioning and to help with surface selection in everyday practice. In recognition of Worldwide Pressure Injury Prevention Day, or Stop Pressure Day today, we of course want to play our part in raising awareness with a particular focus on seated individuals, a group that is often overlooked in tissue viability planning, I think, yet highly vulnerable to preventable harm. It is exciting that we do now have these specific chapters for seating considerations and repositioning recommendations as part of this 4th edition update to the clinical practice guideline. Now, I'm not a nurse, so I do not have the skill set to comprehend all the treatment strategies and so on, but I am a physiotherapist who is passionate about postural care. So I deeply respect the interplay between posture and pressure in relation to things like biomechanics of the body, but also to the quality of life of the individuals that we are here to advocate for. Just a bit of history on the clinical practice guidelines, which were first published as a joint quick reference guide back in 2009 between the European panel and the American and the US National Pressure Injury Advisory Panel. The Pan-Pacific equivalent then joined for the 2nd edition, followed by the 3rd edition in 2019. Now, what makes this 2025 update to the guidelines so exciting, alongside the addition of those specific seating and repositioning chapters that I mentioned, is that they are now free online living guidelines. So the content and functionality is regularly updated, with more chapters coming soon too. This does mean, however, that we should be checking the website and checking the guidelines before citing and following the recommendations, just to make sure that it is all up to date. The format of these new chapters generally proposes a clinical question, followed by a recommendation or a good practice statement. The considerations for implementation are also given, such as how it might apply to a specialist population or a particular client group, along with any supporting information that may be relevant. The updated guidelines use the grade process, which is a highly standardised appraisal process for reviewing any identified evidence to be able to answer those clinical questions that have been posed. The grade process provides a rating for the quality of the evidence, so depending on things like risk of bias, for example, or study design, plus also the strength of the recommendation, which can be impacted by things like that balance between desirable and undesirable outcomes. Do the benefits of that implementation outweigh the harm of not? Just to remember as well that not all high quality evidence, things like randomised control trials and systematic reviews, they don't necessarily lead to a strong recommendation and vice versa. So that's why these critical appraisal tools are so important, so we can balance that up to make sure that we are being as clinically accurate and justifiable as possible. I'm not going to be covering the chapters page by page or recommendation by recommendation, because you could simply go and read that yourself and read through it. What I wanted to do was amalgamate the content and apply the theory to realistic daily practice within the world of seating. While our foundation is these latest guidelines for seated individuals. We'll also be drawing on the repositioning chapter that I mentioned and other key national resources as well, including guidance from the Society of Tissue Viability, which have some great guidance for seated posture as well. Together, these frameworks help us understand how to better assess, position and protect the skin health of people who do sit for prolonged periods of time, or those who cannot achieve their optimum posture independently. Just to highlight that, I will be using terms like pressure injury and pressure ulcer interchangeably. They are in the new clinical guidelines anyway, there's a shift now towards using pressure injury, but when we are supporting individuals and working with caregivers, we may still hear terms like pressure sores and bed sores, and if we need to do that to keep it accessible, then we can just suit the terminology to the audience basically, but just to let you know, I'll be using those terms interchangeably. And also for the purpose of today's session, I'll of course be referring to specialist seating, but there are going to be some individuals who can use standard chairs or maybe on the other end of the spectrum and need to use custom moulded equipment as their form of seating surface, and we can kind of generalise the application to some extent. Before we do start, I just wanted to review clinical decision making and the role of things like these guidelines and research, because we can often get so fixated on them that we underestimate our own experience, our knowledge and our expertise. Remember that guidelines aren't a prescription, nor are they a strict law. They are more of an advisory framework to support us as clinicians. Those of you who have attended our webinars before or have joined us for a face-to-face event know that my overriding desire is to empower you to navigate this often complex world, overly complex world of seating and postural care, and try and make it realistic to clinical practice. Clinical decision making in line with evidence-based practice isn't just about the best evidence, it's also about the individual and about our clinical judgment. And that means that our clinical practice is not only person-centred, but it's also supported by critically placed research and, of course, our unmatchable experience. It's an opportunity for us to advocate for best individual outcomes whilst making sure that our interventions and our management plans are practical, effective and justifiable. So let's set the scene. Pressure injuries, it's believed that they affect over 700,000 people every year in the UK and cost the NHS more than 3.8 million a day in treatment and associated care. Aside from the clear and questionable significant impact on the individual, physically, psychologically and socially, there are also implications on service provision. So some alarming statistics for you now. Pressure ulcers are associated with a 5-fold increase in mortality in the older person. And if they develop, they can result in longer hospital stays. So an average of 5 to 8 days per pressure ulcer, which we know has major impacts on health outcomes. And something that might really help shift this perspective is remembering that our skin is our largest organ that truly protects us. So any damage to it needs to be considered organ failure, right? And when you break it down into these alarming statistics and actually how debilitating and how harmful yet avoidable most of them are, believe it or not, 90% of them are, there's a duty of care there, right, to try and raise that awareness, pass on the knowledge and try and support people to be proactive with prevention whilst also managing those who sadly have already developed pressure ulcers. In the simplest of terms, pressure ulcer is defined as localized damage to the skin and or underlying tissue, usually over a bony prominence, not always, but usually over a bony prominence where there is little fat coverage. Pressure injuries aren't only caused by duration and how pressure is distributed, but also by the presence of friction, shear forces, and the surface's ability to manage things like heat and moisture. Just to quickly note the difference between friction and shear, because they are sometimes used interchangeably, but they are actually two very distinct terms. So friction is the rubbing of skin against the surface, which can break down the top layers of skin, making it more vulnerable to damage from pressure, while shear happens when the skin is held still and the underlying tissue and bone move in opposite directions, such as sliding down in a bed or sliding out of a chair. And when that happens alongside prolonged pressure, it can lead to cell death and the development of significant things like deep tissue injuries. In simpler terms, friction is a surface level drag, while shear is a deeper internal stretch and tear. Soft tissue compressed between the skeleton, so the bone, and the surface can experience ischemia, so where there is reduced blood flow. But research is now showing us that tissue deformation, so the physical changing of the shape of cells and tissues, especially from things like poor posture, can cause damage even more rapidly. Deformation can actually cause immediate cell changes within minutes, while ischemia leads to a more gradual injury over hours due to that build-up of waste products, the lack of blood flow, and the lack of oxygen. Seated postures are uniquely risky, particularly for people with complex needs, the type of individuals and client groups that we likely see within the world of postural care. But just be mindful as well that complexity doesn't necessarily always correlate to the risk, because we can have individuals who might have the physical ability to be active and be mobile, but actually lack the cognitive presence to be able to know that they need to change position. So just be mindful of that. Even individuals who could be active and could protect their skin health themselves can still be at risk if they're not supported to do that, or through prompting and things like that. The presence of intrinsic risk and prolonged external forces is what's significant here. So the individual may be unable to reposition or weight shift independently due to things like weakness, frailty, or motor impairments. Functional independence, cognition, and sensory feedback may be impaired, which compounds that inability to manage and protect their own posture. Resulting destructive positioning, such as sacral sitting, so that posterior pelvic tilt or lateral leaning, increases instability, asymmetry, and therefore unequal loading on tissues, but also shear risk as well when we get the gravitational forces. The addition of that tends to further exaggerate those asymmetries. Malnutrition, incontinence, problems with temperature regulation can exacerbate skin vulnerability. And even a current pressure injury, or even just a history of pressure injury, is also pertinent to understand overall risk. So individuals in sitting can experience these high interface pressures concentrated through a small surface area. The ITs, or the ischial tuberosities, the sitting bones, the sacrum, the heels are all common hotspots. Even in the gold standard sitting position, and I'm sure if we kind of switched all the cameras on now and looked at you all, I'm sure you're all sitting in that lovely gold standard 90-90-90 sitting position, right? But even in that position, around 75% of our body weight is transmitted through the pelvis, so through the buttocks and thighs, and 19% still goes through our feet, even though they're considered a load-bearing role or a transit body segment. So if we're working with an individual who presents with a pelvic obliquity, maybe there's insufficient foot support, or the foot plate has been removed and it's been used as a doorstop, where does that 19% of their body weight go? We suddenly could see 94% of their body weight just going through one point of their pelvis, and we're wondering why pressure injuries are happening. Yet seating is often under-prioritized compared to bed-based interventions, for example. And this will lead to missed risks, can lead to preventable, as we know, preventable injuries, and then sadly higher complexity in care needs because we're suddenly being reactive and not proactive. So to reiterate, the risk of pressure injury in seated individuals arises from this combination of physical, systemic, and environmental factors, prolonged immobility, muscle weakness or movement difficulties, postural instability, poor nutrition, incontinence, and cognitive or sensory impairments, or compromised skin integrity and tissue tolerance. And these vulnerabilities are then compounded by extrinsic seating-specific risk, such as things like incorrect seat width and depth, unsafe use of functions, and inappropriate support services. And don't worry, we'll go through this in more detail as we go through, and then we'll have an opportunity as well at the end to show you that on the chairs. So such factors will increase the risk of shear, reduce pressure redistribution, and can quickly escalate that risk of tissue breakdown, particularly when carer support is inconsistent or repositioning is infrequent. But as I said, we'll cover this in more detail as we go through the session. So with this knowledge, we can now highlight the seating objectives for optimal pressure care as part of a holistic approach. These are, of course, generalised now, and you would need to build upon them and individualise them for a person-centred approach, with the integration of other support services as well and equipment that might be needed across the full 24 hours. The International Clinical Guidelines also have a full body support services chapter that may be worth a review for pressure care in lying, which of course ties in that 24-hour approach as well, to make sure we have effective postural care throughout the full day and night. So we must support optimal postures, thinking about things like alignment, stability, control to reduce those pressure points, and reduce the risk of tissue deformation. We must encourage functional independence, because that participation allows things like micro movements and reduces the impact of immobility on risk. We must enable safe repositioning, considering things like intervals between those movements and the support that might be needed as part of an individualised care plan. And a top priority for us at Careflex is to always promote comfort. Ultimately, this is our way of achieving compliance by increasing seat intolerance. So our clinical objectives are not going to be met if the user simply won't use that piece of equipment. So let's work through then the principles of postural assessment and seating prescription in relation to pressure care, using some of those good practice statements from the guidelines. So where do we begin? And well, it has to be really, the starting point has got to be that comprehensive postural assessment, which can only then be followed by an effective seating prescription. It should never be superficial or underestimated. These are topics that we cover in depth during our roadshows, so our face-to-face events. So please do reach out if you feel this is an area you would like to develop, looking at things like assessment techniques, critical angles, trunk symmetry, and so on, and how we obtain that information that we need. So we must consider the person, including things like their own goals and preferences, and we can break that down to subjective information gathering and objective data collection, including things like their health history, care requirements, their cognition, communication, nutritional status, and of course their skin health, before then looking at their body shape and size, weight distribution, mobility and functional ability, postural challenges, critical angles, and sensory impairments. And as I said, that's something we covered in detail in our roadshows if you felt you needed to develop those assessment skills. If someone has been confined to bed, for example, or to improper seating for a long time, then a gentle and gradual approach will be needed to adjust to this new upright sitting position against gravitational forces. And a robust review process is also essential to make sure we get that person-centred care. So please consider how you're going to implement that if you do work by a case-by-case basis, especially those in community where you get a referral, you do the work and discharge, making sure that care plan is informative and they know, and the caregivers know what to look out for and how to request a review. The next step is then looking at the chair, of course. Does it support the right dimensions? And does it allow for effective setup? Does it promote stability and postural control? Is it adjustable for changing needs? We can use the diagnosis, an idea of prognosis there to look at things like longevity, but even rehab potential as well, and how we adjust the chair to manage that. Does the chair integrate into daily life? Asking about what usual seated activities they do and how do we make sure that we enable that, because again, we need compliance with that piece of equipment. And we can look at the chair in a bit more detail as well, as I said at the end of the presentation. The take-home message here is that it's critical to understand not only the benefits of specialist seating, but also the risks too. It is a medical device and it is integral to health and well-being. The next step, we have the caregiver or the support network, who of course play a role. Are they competent and confident in following the care plan? Do they know about repositioning and safe use of functions? Can they identify risk for early proactive prevention strategies? As of course, especially in complex needs, we do heavily rely on them because we simply cannot be there 24/7. And then the final step then is thinking about the environment. Even if we get those 3 steps right, a clinically sound chair can still fail in practice if it doesn't fit the environment or the care routine. So they've got to be compatible, thinking about the logistics, compatible with doorways, beds, tables. They allow enough space for carers to assist safely. Transfer compatibility is thought through. A perfect chair that can't be reached by a hoist or isn't compatible with a stand-aid like a steady, or doesn't enable independent transfers, is going to go unused. Think about as well things like maintenance, surfaces being, is it modular? Can we break it down? Can we clean the surfaces? Is it durable? Is it easy to adjust? And then of course, the training, and we'll talk about caregivers later, but actually even the best seating plan will fall apart if the individual and the support network don't understand how to use it. Just to say as well, when integrating these guidelines into it, the seating chapter of the guidelines does reinforce this as well by stressing the need for evaluating risk level, postural needs, dimensions, activity and preferences for this true holistic approach, and kind of bringing all of those aspects into pressure injury prevention in sitting. So how does all this look in practice? A crucial step in that process is a specific risk assessment. Whose duty this is will depend on the roles and responsibilities, I guess, within your organisation. But there are some simple to use tools out there, such as the Braden scale or the Waterloo score. I believe that a lot of NHS trusts, especially in England, employ the Purpose T risk assessment, which does actually prompt the assessor to use their clinical judgment and wider knowledge of the individual. But regardless of the tool or who should be completing it, it may be worth investing in the time as part of your postural assessment, just to be able to categorise risk, as it may highlight a key factor that would otherwise be missed, or the need for signposting to district nursing or tissue viability, for example, for specialist support. Once we've completed that comprehensive yet holistic assessment process, we should then have the necessary understanding to start forming our interventions. As I've already mentioned, signposting or onward referral may be indicated. We might need to do some multidisciplinary work in here. There might be a need for a medical review or medications review with further diagnostics, for example. And that's why the assessment is really critical to find out all that information. From a seating selection focus, though, we can now work our way through the provision collaboratively with the seating provider and the seating assessors. And just remember, the provision must be person-centred, because that's what promotes that compliance, which allows us to meet our clinical objectives. Chair selection is not one size fits all. It must be clinically appropriate for the level of risk, for posture, for mobility and function. It must be adjustable to suit evolving needs, whilst enabling things like functional engagement and participation. It must be supportive of repositioning through independence with transfers, but also caregiver support, whilst also considering that seating tolerance as well. And it has to be aligned with lifestyle, with goals and care context and routines. Be aware as well that there are other standards and evaluations out there that may support seating provision, such as the ISO standards, the international standards. As it is a medical device, there are other considerations beyond pressure injury prevention, of course. There are, we might need to consider wheelchair and cushion standards, like RESNA, and I've mentioned about ISO, that give us information on things like performance, safety and postural support as well. There's lots of support out there, lots of information. So again, if you kind of wanted some tips and guidance on where to look for that, then just let us know. Okay, so let's get back to the seating then. The basics of chair setup truly is the foundation of safe seating, and sadly sometimes it does get overlooked. Seat width, seat depth and seat height must be measured against the person using the chair and not just assumed, especially in multi-user environments. We have to have that adjustability between users. If the seat width is too wide, they're going to lean. If the seat depth is too long, then they'll be pulled into the sacral sit-in. If the chair is too high, then they're going to slide down the chair. We can demonstrate all of this practically later, as I said. Armrest height may also be important for independent weight shifting and encouraging activity through functional movement. We might need to think about padding as well to obviously protect skin health. Getting those basics right is important to get that proper fit, because that's how we ultimately get that postural stability and control. If we don't have that, we will see an increase in things like shear, and immersion might be reduced, and it can definitely undermine our repositioning strategies as well. The critical angles for sitting also need to be considered to support postural security and comfort, and you'd find out that data through your assessment, having a look at knee range of movement, hip range of movement, for example. Remember that the chair is only as good as how the person is positioned in it. So that setup must then reflect positioning, movement and handling guidance. Is there a need for signposting for that specialist input as well? Do you need a movement and handling profile alongside your care plan? And again, that depends on kind of your service provision and your organisations, but that might be something to look into. Next, we must ensure adequate postural support within the chair. So as much of the person in contact with the chair as possible. We've got to ensure that those seating systems maintain optimal alignment to help reduce localized pressure. The goal is symmetry, midline alignment, and functional pelvic stability. So getting that pelvis and spinal support is going to be vital for that security within the chair, but it can also help manage abnormal movement patterns, which also then reduce the risks associated with things like shear and instability. Foot support, non-negotiable. Obviously, there may be exceptions to that rule if somebody does have particular tissue viability input and we're concerned about things like hotspots at the heels. And again, what is this leading towards more bed-based support? But you might need to seek that special support there. But when it comes to proprioceptive feedback through the feet, getting that postural stability, we have to get the feet supported. Studies have demonstrated that peak interface pressures can be reduced at the ITs, at the ischial tuberosities and the sacrum by using a foot support when seated upright. A supportive chair will be able to improve pressure redistribution. So with the right postural support, we're of course getting that alignment to reduce things like slumping or shifting and leaning and some of these compensatory postures, habitual postures, destructive postures that we might see. Where positioning aids may be indicated for stability, or even things like in situ slings as well, if it's too destructive to try and remove the slings as part of that transfer. That does need to be weighed up against the risk of pressure injury, along with any devices that might be in situ as well, because obviously it disrupts the connection between the skin and the supporting surface. Advanced systems can and should integrate specific cushioning. So if somebody does need a particular third-party cushion, that should be integrated into the seating system, which would be through something like a docking cushion to make sure they have that seamless fit that doesn't affect functionality and doesn't increase the risk of things like entrapment either. So making sure that the pelvis sits where it should. within the seat and support surface, because usually these cushions are measured to the individual, whereas of course the chair itself is adjustable. So we need to make sure that our chair is a seamless fit, that cushion is a seamless fit for the chair. We also need to support well-being, and this falls within one of our core seating objectives as well. You know, we of course have postural care and pressure care, and things like function and comfort, but ultimately we have to support well-being. We are here for the individuals. They are the reason we probably became therapists, and we need to advocate for them. So we have to bring it back and centre it around them. The chair must do more than just hold the body. It has to support movement. Postural stability is critical to enable, so that proximal stability, is critical because it allows distal control. So it frees the upper limbs from their load-bearing role for activity and participation. If somebody feels unstable, we may see them doing things like clinging onto the arms of the chair or anchoring themselves into the corner, which of course is going to restrict their participation in daily life and engagement with the world around them. This is also a key prevention strategy because we know that limitations to mobility increases pressure injury risk. So moving the body, taking the joints through range and getting blood flowing will protect the body structure as well. We must balance safety with participation and ensure that things like dynamic features, so when we talk about tilt and recline, are not used excessively and used appropriately and safely. Because they can be valuable for those who need support and can't do it independently, because they allow, especially tilt, allows offloading without disrupting postural control. But function must remain central. So a chair that reduces pressure but prevents someone from engaging with their environment, communicating or eating safely isn't a solution. It's just a compromise too far. The guidelines as well call out the need to balance clinical risk reduction with function and engagement, particularly for long-term users, those who are going to continuously be at risk of pressure ulcers, those who are maybe wheelchair users, for example, or have particular conditions that put them at risk. It's also worth noting as well when we talk about well-being, there's an interesting bit of data that I always bring up. Research has shown, so when we think about individuals who maybe be confined to a bed, I don't like the term unseatable. I like to think there is a solution, even if it may be a compromise, even if it means redefining seating objectives, there is a solution to get somebody out of the four walls of their bedroom, even if that's for 20 minutes of a day, because well-being is just so critical. Research has shown that loneliness and isolation is actually twice as harmful as obesity, not just to physical health, but mental health as well. So we've really got to try and get people interacting with the world around them and participating and engaging with loved ones. So that slide then leads us nicely on to the next step, which is ensuring safe use of the chair and thinking about those said functions that I mentioned, like tilt and recline. This is critical because it could actually negate all the hard work that we've invested in setup and postural support if the individual or the caregivers using the chair don't understand functionality implications. For example, tilt function can positively support pressure redistribution, while recline can actually negatively impact pelvic stability and increase shear force. Leg rest elevation too is also a significant contributor to shear forces when the critical angles for sitting aren't respected. And we can kind of demonstrate that to you later during the Q&A if that's something you want to see. There are recommendations out there on safe and effective angles. Studies have demonstrated that skin perfusion significantly increases when tilt in space is combined with the recline position, if that's appropriate. So around 15 to 25 degrees of tilt with 120 degrees of recline. But remember, when the pressure is offloaded from those regions, it's still redistributed to other pressure points. So we still need that regular change of position. Using recline feature and isolation, as I said, increases shear forces. So it's wise to use tilt in space before activating recline if you were going to use them in combination. Now, as I said, the chair is only as good as how it is used going forwards. Even the best seating system, the most advanced cushion, the most precisely adjusted chair cannot eliminate the need for movement. And I cannot emphasize this enough, especially as a physio. It's not about one perfect posture, but a realistic, achievable positioning strategy. We could set up the chair to the person's optimum posture. I don't like the term perfect or good, but that person's optimum posture. But then if they still remain static for the next 8 hours, then they're going to be at risk of skin breakdown and body distortion. Repositioning remains central to pressure injury prevention, and all the guidelines and evidence-based points towards this. The repositioning guidelines, a chapter that I mentioned, emphasise that no support surface can remove the need to offload tissues. So regular movement reduces the sustained tissue deformation and supports circulation. Micro movements are ideal, as frequent as every 10 minutes if indicated, and for a duration of at least 30 seconds. Even small shifts in posture will make a difference, and dynamic seating functions can support this. That can be turned into daily habits by scheduling them into current routines as well. Manoeuvres like rear tilt, lateral leans, forward leans, and push-ups. Again, there might be a bit of a training need there to hand that over to individuals in the care team. Where possible, research has shown that we should aim for a posture change every 2 hours, but always based on individual needs and tolerance. The optimal method and frequency hasn't really been ascertained through any comparative studies. So that ability to self-reposition is going to be an important consideration. Can they do those micro movements themselves? Which will help guide you to understanding how long an individual at risk should spend in a seated position, what those intervals are between movements and changes of position, thinking about those intervals. Regular skin checks that will also help determine individual skin tolerances. So it's kind of saying how long's a piece of string. And that's why these are guidelines and not a strict law, and they have to be individualized to the person. If it's a new piece of equipment, then definitely err on the side of caution, and you might want to be just doing 30 minutes and doing those regular skin checks for a period of time before gradually increasing that. With any form of postural care, it should always be a gradual, gentle approach anyway. Some people may only tolerate those sitting periods for short lengths of time. Others may benefit from things like those dynamic tilts. How do we bring that into the care plan? Do we need things like auto tilt if somebody is independent at home to reduce the need for care calls? There is no universal rule here, sadly. It's got to be clinically reasoned, and it has to consider the individual's risk profile. Their skin condition, their pain, their posture, their tolerance will help guide that schedule for you. But again, that multidisciplinary approach, specialist input may be indicated to, raise your confidence with that. In some cases, short periods of bed rest may be clinically appropriate too, especially where severe pressure injuries are present, but that has to be, of course, carefully balanced with functional goals and the risk of deconditioning that we know can happen very quickly when somebody becomes confined to bed, losing muscle mass, affecting things like blood pressure. It can be really detrimental to their ability then to regain sitting postures. Ultimately, movement is an intervention as well. The chair is what simply enables it. It doesn't replace it. I mentioned about shear being one of those kind of hidden but significant risk factors. that can often get a little overlooked, especially within the world of specialist seating, because the chairs themselves and how functions are used can actually increase the shear forces. So that's why I said it's about understanding benefits as well as a risk. They are medical devices and they have to be respected that way. The same way as taking the wrong medication can be detrimental, using the wrong chair and using it in the wrong way can result in significant harm to the individual. So to minimise things like shear, we of course have to stabilise the pelvis and trunk, maintain proper alignment or optimal alignment, hips, knees, ankles, to prevent those sliding movements and those drag movements. We can use things like tilt or tilt and recline to redistribute pressure and reduce shear during prolonged sitting. We need to make sure that we select low friction materials for things like cushion covers and clothing to reduce that drag as well. But also be mindful when I mentioned about things like in situ slings and positioning aids as well, because they obviously are affecting this support surface. We need to support transfers, maybe with assistive devices and safe techniques to avoid, again, that dragging, that slipping and sliding across surfaces. Education is going to be key here for caregivers, because it's critical that those strategies are applied consistently, because as I said, tissue deformation can happen within minutes. And we'll look at kind of care planning in a bit more detail shortly. The material components of a chair play a critical clinical role. It's not just what the chair does, it's what it's made of as well. So surfaces must allow the body to sink in, so immersion, whilst also conforming around the body's contours, so envelopment, to redistribute that load effectively. That in turn will reduce pressure, manage shear and support microclimate. We want to avoid surfaces that trap heat or trap moisture, because that just increases maceration and skin breakdown. The wrong surface, no matter how well set up or functional, can undo all those other efforts. And that's why cushion selection, material selection must be clinical and not habitual. When we think about support surfaces, we've got to move beyond just pressure. As I said, we need to think about shear and managing microclimate, controlling temperature and moisture to protect skin integrity. So materials that wick away moisture, reduce heat buildup and minimise macerations, as I said, especially in high risk users. And that's just as important sometimes as that shear reduction. The guidelines recommend pressure redistribution cushions, things like contoured foam, gel, water cell and air cell designs, but it has to be tailored to different postural needs and risk profiles. Again, apologies, I can't give you a strict answer here. It depends on the individual, and your clinical judgment and experience, but also preferences as well. What do they find comfortable? What do they find stable? It's got to integrate into the seating system, so not a cushion placed on top of another cushion. And I'm sure we still see this out there in clinical practice, but that will increase postural stability. It will increase shear forces. It'll cause misalignment, which then, as we know, leads to unequal loading of the tissues. Four-way stretch breathable covers can support that pressure care, because it allows it to conform to the contours whilst permitting that air exchange and heat dissipation. Donut cushions are actually contraindicated in the guidelines because they concentrate pressure around the edges, leaving the central tissues at risk. We've got to think about weight limitations as well, of course, when we think about cushion use. So just remember that cushions alone, and it's something that kind of always gets brought up in terms of pressure, injury prevention and care in sitting, about this big focus on cushions. And we get asked if we can purchase, individuals ask if they can purchase our cushions to integrate into other systems, but it's actually about the whole seating system. A cushion alone does not prevent pressure injuries. It's got to be part of that comprehensive postural care plan, and it's got to be reviewed regularly as well for effectiveness. Just wanted to bring in some other kind of national guidelines that are in place. I mentioned about the Society of Tissue Viability. They're also always guidelines as well, and they provide some quite useful tools that can give a bit of a structured approach to pressure care if you feel you needed that guide and step-by-step process. So this is the Askins framework, breaking it down to assessing risk using things like the screening tools I mentioned, but also preference and clinical judgment as well. Skin, inspecting at-risk areas regularly. Discomfort may be absent. Again, just because somebody's comfortable doesn't mean their pressure care is at its optimum either, and that's a fine balance to tread. Surface, the tailored seating provision. Remember, not one size fits all. Keep moving, making sure we get that schedule supported repositioning, so there's personalised strategies within the care plan. Incontinence and nutrition, managing those contributors to skin fragility, well-balanced diet, fluid intake, but also seeking specialist support if it's needed. Sickness, because we know that healthy lifestyles is critical, because becoming unwell increases your risk of pressure injury. The keep it moving section there, particularly relevant for seated individuals, because we don't want them in that one static position. As I said, it's got to be supported by education, by care and involvement and accessible equipment. This is the Always Guidelines 4S model, again, breaking it down into size. So making sure the chair dimensions, that basic setup is correct. We involve in adjusting every component, making sure we've got postural support at every body segment. Surface reminds us that cushion choice has got to suit the individual, and it's about integration with a full seating setup. And then shape, focus on using contours, lateral supports, different back styles to get that immersion and envelopment, but also to align the body as well to reduce that asymmetrical loading. Ultimately, a person sitting on a high spec cushion in a poorly fitted or incorrectly adjusted chair remains at risk. So this is, again, another good holistic approach to that. There are things we can help with independent wheelchair users as well, and I'll kind of share this presentation because I'm conscious we want to kind of get through a Q&A session, but education on self-repositioning might be needed there. Perceived movements versus actual frequency can differ. Pressure mapping can help illustrate actually how static somebody is, and they may need prompting for that. And then, of course, the support network and that holistic approach that I mentioned, making sure that we get that compliance. If we have all the data and all the information, it can help guide appropriate seating provision. And of course, the support network is part of that. We've got to consider their competencies, they're confident, which may lead to a training each year. And again, that's something we can support with if you are working in multi-use environments or care teams where there are care flex seating. Again, let us know. Education should be proactive, not reactive. During our handover process, it's just going to be a key step to make sure that they understand how to identify risk and seek support. They should know what to report and how. They should know how to check alignment, notice slouching, reposition. If education is left until that harm happens, then we've already failed. So it's proactive, not reactive. And then finally, just to mention about the care plan that I've been speaking about and how we really consolidate all that information. When we leave our environment, we can't be there 24/7, having that confidence and empowering other people as well to continue to use the equipment and interventions as they should be, to make sure that we have long-term positive outcomes. But if needs do change, they know how to seek support and come back in to the service for a review. So we need to think about accessible guidance based on cognition and communication needs. A 24-hour timetable can be the simplest way to demonstrate repositioning regimes. The use of images can also aid that ability to replicate guidance daily better than words can. And then making sure that all the risk factors are evident, contraindications, precautions around things like functions, recline, leg rest. We might actually have to physically lock off some of those functions on the chairs, but we can help with that. And then, as I said, that robust review process, highlighting risk factors and red flags that people need to look out for, that would highlight the need for a re-referral and review, such as new red areas noticed during the skin check, a change in behaviour, fatiguing more quickly, or asking to go back to bed. Just to finish my last slide, just wanted to really do some myth busting, and this might be an interesting one to kind of share if you're really struggling with individuals or care teams and getting them on board. And I'm sure you hear some of these statements out there, and sometimes it's not coming from a negative place either. It might just be a gap in their knowledge or a lack of awareness, and it's our role then to fill that. So if they're upright and out of bed, they're safe. Well, that's false, because just being upright doesn't guarantee good alignment. True safety requires a full postural assessment, not just a visual glance. Any cushion is better than none, which we know is false, because an unsuitable cushion can create new risks like shear and instability. 2 cushions are better than 1, cushions on top of cushions. Again, false. Layering those cushions can compromise on immersion and stability, leading to higher peak pressures. If they have a good cushion, we don't need to reposition. And again, as I said, the cushions reduce pressure, but they don't eliminate it. We need regular movement, because even the best cushion can fail. So it's all about regular repositioning and those micro movements and larger full changes of position. We don't need to reposition if the chair tilts or reclines. So again, false. Tilt and recline assist low distribution, but they don't really replace the need for offloading, because it obviously just goes to a different part of the body, especially if not used frequently or correctly. And then we don't have the time to reposition. And yet there's always time to manage a wound. Prevention is more humane, it's more cost effective, and it's less labour intensive in the long run. So just some things to think outside of the box there and challenge some of those assumptions. Okay, I think we're back on the screen. I appreciate that's a lot of information, so thank you for bearing with me. I'm just really excited about these new chapters, and it's all very well kind of reading through them, but actually how do we apply that theory to clinical practice, especially within specialist seating, that I know the barriers to provision. I know that you're probably struggling out there with resources and funding, so maybe this might just help that clinical justification for you as well. Are there any questions, Kiwi? Anything come up?
Yeah, we had a few questions. The first one is there a link to that study that was included about loneliness being more harmful than obesity?
I can provide it, Kiwi, if you give me a nod, I can provide it. It's Holston Lundstedt is the research, but yeah, we can maybe send it out with the certificates. It'll be on the presentation as well, so there's a reference list, there's a slide with all the references on there. They'll go out with the presentation as well, but yeah.
Perfect. And I've got a question, is how does using the tilt in space feature first and then using the recline function apply with rise and recliners when there's no tilt in space features? What would you suggest instead?
If pressure care is concerned or stability, is rise and recline the right option for them? If there is no tilt, that would be the question I'd probably be asking.
Choice of functions with rise and recline as well. You know, you can isolate the different movements. You can isolate back and recline.
Yeah, so that might be something to look at. Maybe it's just something that can be adapted.
It's quite often rise and recline is a linked movement. So as you recline or tilt, the legs elevate. That's an option. There are other options you could consider for your rise and recline seating to isolate those different functions.
Yeah. But it's definitely, if we do that recline first, then we are increasing that risk of shear and postural instability, because there's nothing preventing and stabilising that pelvic movement. So a slight tilt just helps to ground that before we bring the recline in. But certainly that might be something to look at, maybe something that can be adjusted on that chair. Or it might be a case if rise and recline is needed, do we need to look at different functions? Do we need to kind of separate the motors, I guess, and have tilt and recline? Or if you are particularly concerned, is it a need now to move up to specialist seating? I hope that answers that.
Thank you. Our next question is, when talking about integrated pressure cushions, what about cushions that sit on top of each other rather than integrate?
In those instances, I would definitely consider a docking cushion. It's when it comes to specialist seating, again, depending on, obviously, people if tissue viability is involved, But again, that might be something to challenge with tissue viability in question. Does this cushion need to be on top of this cushion? Is there a way that we can integrate this? Because definitely from the research and the data, it's about integrating cushions, having one seating support surface, because if we layer cushions, we do increase instability, which increases shear and obviously the risk of leaning and misalignment as well. So I mentioned a docking cushion, and maybe wasn't very clear about that.
Part of it, Tim.
Yeah.
I mean, we have a standard range of accessories and products, but we also have the ability to manufacture bespoke components to a chair. So a docking cushion would house, if you like, that third-party cushion to hold it nice and centrally, so that the pressure care elements remain in the correct place, so that nobody walks off with the cushion.
It doesn't slip and slide.
Doesn't slip and slide.
Make sure the ITs go into the right place. I mentioned the ITs a lot, and just to mention again, if you're kind of new to it, I mentioned, I don't know if you can see, I mentioned ITs quite a bit, and it's these bony prominences, the ischial tuberosities at the bottom of the pelvis. If you sit on your hands and have a wiggle around, they're called the sitting bones, you can feel them, and they're quite high risk areas. And if they don't fall into the chair where they should be, we could have gaps behind the pelvis, which obviously forces our sacral sitting. We could have shifts, lateral shifts as well, especially if hoisting isn't appropriate into the right place, which again causes that misalignment to get unequal loading on tissue. So hopefully you can see how interlinked posture and pressure are. So definitely in those cases, challenge, why is there a cushion on top of cushion in the first place? Is there a way that we can integrate this into the seating system instead? Because it does significantly increase those risks. When we said about docking cushion, it is just like an inlay, like Les said, just like a cutout, and the cushion slots into it. So we still have functionality in the chair as well, with things like seat width and seat depth.
Thank you. Next question is that it was mentioned that elevating legs increases risk of pressure injury, but sometimes we recommend that people use the elevated leg rest to provide a stretch.
Again, it depends on the individual. That's why you have to look at critical angles. You have to understand sitting, their tolerance. Should we quickly show? Actually, so when we talk about posture in relation to pressure, I mean, there are, please. There are going to be obviously incidents where leg rest elevation might be key for things like edema, as long as obviously you need to elevate the lower limbs higher than the heart to be able to achieve that. There are going to be comfort reasons for doing it. It does offer a bit of a weight shift, but if we don't do our postural assessment and understand critical angles, so knee range movement, for example, leg rest elevation, if they don't have the range to tolerate leg rest elevation.
Guess your seat depth.
Good guess. Not bad. Good guess. So if you imagine that I was limited to kind of almost in a 90-degree position, I developed fixed deformities or a contracture of the knee, either through spasticity, through hypertonicity, through a lack of provision before or input, and it's been unmanaged, or I developed these contractures, and suddenly leg rest elevation brings in. Remember, I can only maintain 90 degrees because I'm fixed. My soft tissues are shortened. I can only maintain that.
And you just look how much of you now in contact with the chair.
Yeah, we have the gapping happening. What we'll then see, because gravity, body parts are heavy, we could see the wind sweeping happening. I now have that instability and malalignment at the pelvis, increased pressure going through the right side because the obliquity is happening. So it's just this chain of events that happen. Don't get me wrong, there are cases where we do use leg rest elevation as an orthotic device. So if somebody does have soft tissue shortening, so it's not a bony contracture, and there's scope there to be able to achieve more range, then we can use it as an orthotic device to get this passive, again, the research and the debate is out there on where the passive stretching and prolonged stretching affects. But we can use it as an orthotic device, but again, that has to be very carefully put into the care plan, because people have to understand where to stop that leg rest elevation before, that range and that tolerance before it affects the pelvis.
Thank you. There's a few more, I think 3 more. I've got any tips for working with ward culture that is not proactive about pressure issues, especially in seating?
Training.
Yeah, I mean training, but it's probably a training that would be a focus on the benefits for service provision and for their working practices. Of course, person-centred is always, you know, going to be at the forefront, but in those busy wards where there is a cultural challenge of, you know, being busy and lack of time, lack of resources, you know, swinging those benefits around to actually how this can help you, because if we set up the chair appropriately, if we manage stability and alignment, it means that we can support that individual for a longer period of time. Of course, we still need a regular change of position, but it means that they can maintain that stability. So they're less likely to shift, to lean, to fall, to slump, and less likely to require significant repositioning. So it should actually lower the amount of interventions that they need from the care team as well. It's just maybe thinking outside the box on how it could benefit them, lower complexity, lower the intensity of the interventions that they need to do.
We're often involved with kind of awareness sessions. We can host those. We can come to you to do that kind of training session, and it's quite interesting to watch reactions of people who don't fully understand or appreciate the range of capabilities that the chairs can present for people. So
it could just be a confidence thing, you know. It might just be getting somebody to play around with the chair to realise how simple it is to change something like tilt and space, where that might have been quite daunting before. That might just be a, you know, a familiarisation session or something, but definitely thinking about the spinning the benefits for them and how it can help their working practices.
Perfect, thank you. I think I've just got 2 more quick questions, which is, can you leave a sling or one-way glide sheet on top of a pressure cushion?
I mean, we know it happens. We don't see one-way glides being used just because of the risk of shear that happens. It's the same. It's the same with positioning aids. Of course, they play a role, and there's going to be individuals who need 4-point pelvic straps. I don't want people to be scared of using them, but they have to be used appropriately, because if we're just plastering over like a one-way glide, that's just plastering over. That's not finding out the cause of that movement. So what you're doing is you're putting that one-way glide in. The pelvis is being stabilised, but that movement, that micro movement, that shift of the pelvis is still going to happen because we haven't understood why it's happening. So actually what we've done now is increase shear because there's nowhere for that to go and that deep pressure that's happening. We don't tend to see those, but there are going to be cases where slings, if somebody, for example, if somebody has quite active, erratic movements who's hoisted, it can be quite difficult to take the sling away after positioning. That could actually weighing up when I said about balancing the benefits against the harm of doing an intervention. Sometimes removing that sling could actually make the whole posture then go off kilter, or we could see the tone shoot through the roof.
It's part of the individual.
So we might need a sling to stay in place because we've weighed up that balance, but then you would need it to be an in situ sling. So there are different materials and choices and kind of seam-free options to try and reduce that risk. But anything that comes between the individual and the cushion will impact on the pressure care that's given. So you do have to weigh that up to understand what those risks are and whether it's worth doing that. I'm sorry, I can't be kind of stricter with that guidance, but
it's very difficult to give an absolute answer to a lot of
but it's good that you're asking those questions. That's what I wanted from this, is for people to start thinking and challenging and myth busting and challenging those assumptions to see, actually, can we do this better?
Thank you. And then the last question is, when there's a peg feed in place, can tilt and space still be used?
This probably is something, again, that would need a multidisciplinary, faceted approach. We do say to be mindful of medical devices, catheters more so with tilt, just because obviously where the kind of where the tube sits, and you know, when we elevate, when we tilt the chair, we can suddenly start seeing the kind of the hips higher, the lower limbs higher, so we can sometimes get backflow. So catheters more so to be mindful of. I have worked with individuals who have pegs and can safely use tilt. Again, there might need to be a kind of a feeding regime, especially around things, just be mindful, you know, of how they tolerate their feeds. You know, when you think of digestion and constipation as well, do they need to be upright for a certain amount of time before tilt is going to be appropriate for them? So again, maybe, you know, speaking to dietetics for advice, just to maybe understand a bit more how that fits into the regime. I have seen tilt used successfully with individuals, but it's going to have to be individual risk on how they tolerate that.
Brilliant, thank you. I think that's all the questions.
If we haven't got to, because I appreciate the chat is probably very busy, if we haven't got to some of these questions, then please just when we send out the information, just follow us up with an email, and we can get back to you. And we said about the presentations going out and the references and everything is on there.
It's our favourite time of the year at the moment, isn't it? It's not just Christmas.
Yeah.
It's the OT show next week, so we'd love to see as many of you as possible. If you'd like to come along to the stand, it's at the NEC in Birmingham. We're easy to find in the hall. You'll be the first left as you come in from the main entrance. I think it's E1. Did you say the stand number was, Kiwi?
Yes, stand E1.
So yeah, we'd love to see you. We'd love to see you all coming onto the stand and saying how much you appreciate these sessions. Keep us in a job.
In front of our boss.
Yeah, that's very, very important for us. So just remains for me to say thank you for attending. Hope you enjoy the rest of your day, and we'll catch up with you soon, hopefully next week.
Yeah, thank you very much.
Thank you. Bye-bye.
Bye.
Bye-bye.